Okay, so I'm going to discuss sort of the paperwork and kind of everything we do to process a surgery patient as they're coming into the hospital. So basically, before their surgery, we send them home we send the owners home with a surgery information packet. This is a description of the procedure, of the anesthesia, thing, instructions for the owner, what time to drop off in the morning, what time to withhold food the night before. So they have time to read that over. And what it also has is a consent form. This has the patient's signalment on it. So the owner's name, patient, species, breed, age, and sex of the patient. And this is a line for the procedure that we plan to perform on the patient. So because we are paperless here for the most part, all of our patients' files are kept in a computer system. So when the patient checks in, I can pull up their file, look at their past medical history of this particular patient. This particular patient we've only seen one other time because they just came to get an exam, to get him established to get neutered. We do preoperative blood work on every patient that we're putting under anesthesia. So while I'm in his file, I can go in. So here's the patient's file. While I'm in here, I can go in, see if they've had any medical history of any known medical conditions or diseases. This is a puppy, so he's healthy. This is his preoperative blood work that I can go and look at, and also the doctor can look at on the morning of surgery, just to verify that there's nothing they want to recheck as far as the blood work goes. So yeah, this is the patient's permanent file on the computer, so we can go in and double check anything if we need to. So on the morning of surgery, the owner will bring us back the surgery packet, everything's signed. I will check them into the computer. It'll pull up Tucker's file, if for example, Tucker. So it'll pull him up in the computer. There he is. I'll verify that he is a male golden doodle. I'll verify with the owner that he is here to be neutered and that he has not had breakfast this morning. I'll also ask the owner kind of how he's doing this morning, if he seems lethargic at all, or if he seems like his normal self, how he's been for the past couple of days, just to make sure that he hasn't like vomited in the past 24 hours or something like that, because that would be something that the doctor needs to know before proceeding with anesthesia. So once he is checked in and I've got their consent form and everything verified, then I will bring Tucker to the back and get him set up in a kennel. So once Tucker is set up in a kennel, then I would take his cage card here, and I would write his name and his owner's name, or his last name, owner's last name. I would also write that he is here for a neuter. And then I will also, before putting him in the cage, get his weight, and I'll also write his weight on the cage card. And then I'll also indicate the color of his leash and his collar, just to make sure we keep all of his stuff, keep track of all of his stuff in the same area. Another thing, okay, so the other form that we use on surgery day is going to be the anesthetic journal. This is sort of like the anesthesia log. This follows the patient around throughout the day. It gets used. So first what we put down is their signalment, any known medical conditions, obviously patient name and all of that. So we have their species, breed, gender, age, attitude. This is where we put if they're bright and alert or otherwise. Then you go on to the physical exam part. So their TPR, got the CRT right here, heart rate, respiration rate, their weights for the day, how much they weigh when they come in. We also go ahead and calculate it to kgs, so it's quicker to calculate drugs. This is also the sheet that we calculate drugs on. The procedure, the surgeon, technician, and also the fluid rates and the type of fluids, if that is what the doctor requests for the surgery. Down here is a list of all the medications that the patient is going to receive, the amount, the time given, and the route. So we have it pre-med, induction, pain med, and then other meds. This is sort of where you can calculate your drugs, the list of the drugs with the dose, the concentration of the drug, and this is how it is given. Down at the bottom, this is the anesthesia log that the surgical assistant or the technician running anesthesia is going to fill out. Whoever is monitoring the anesthesia for that procedure. So this kind of logs how the patient is doing during the surgery. This is a great way to note any trends, which is important because then you can see if immediately something is very different. So it's got the percent anesthesia, the patient's temperature, respiration rate, SpO2, heart rate, blood pressure. And then at the bottom here, surgery time, E-tube size, post-op temp, whether or not we used a non-rebreather, oxygen rate, and then of course we always trim nails, clean ears, and do a microchip if the owner elects to get a microchip at that time. So this is another one of the forms on surgery day. So the last form that we use on our surgery day is to go home with the owner of the pet. This is our post-op home care form. It kind of generalizes the instructions that you're going to go over with them in person. Discharge instructions are very, very important. It's very important to slow down. Take your time explaining everything thoroughly to the owner. Make sure that they have no questions when they walk out that door. Also important that they know how to contact you if they do have questions. So basically go over any sort of complications to look for. So vomiting, lethargy, not wanting to eat, diarrhea, is the incision healing well? Does it look infected? They know their pet better than anyone else. Other things that can go wrong. Any other complications are going to kind of depend on the surgery and be specific to the surgery. Any other complications are going to be specific to the type of surgery that they had. So it's important to go over those with the owner so they know what to look for. The first bullet point on this form talks about the first night of surgery and feeding. Basically, they haven't eaten all day. They had a lot of drugs that could possibly make them nauseous. Start with water, a little bit of water. Only feed them half the amount that they would normally get. So explain that if you feed them too much too quickly, they can get an upset stomach. If they need to switch up the food, instructions on how to do that without causing an upset stomach. how to make it enticing to them if maybe they don't really want to eat, you know, heating it up. It may be necessary to soften the food if they're on hard food and they had a dental procedure. The next bullet point on here talking about how it says expect your pet to be somewhat, okay, so the next bullet point on here talks about, you know, how the pet sort of should act. Basically expecting them to be lethargic for the first couple of days after surgery. If it's any longer than that, please let us know. Also, if they're going home with any drugs that are sedatives, to alert them that that is going to be a side effect as well. Instructing the owner to check the surgery site at least once a day. Looking for missing sutures, looking for inflammation, swelling, discharge. Contact us immediately. The next thing is to keep your pet from licking or chewing or scratching the incision site. You know, do they need an e-collar? Do they need an e-collar? Do they need a onesie? If the pet goes home with the bandage, instructions on how to keep the bandage dry and clean, how to keep the pet from removing the bandage or destroying the bandage, how the pet needs to have reduced activity level. For most surgeries that we do here, it's going to be for about 14 days or like until the sutures come out. This is to prevent a seroma or to prevent the sutures from coming out. If they've had like an orthopedic surgery, it's to help with the healing of that. So stressing the need for reduced activity is very important. You know, running, jumping, exercising, short controlled leash walks, and then back to resting. Keep the incision clean and dry. No baths, no swimming, no lakes, rivers, no dog parks. Of course, that goes with the resting one as well. No soaps or topical meds unless indicated by the doctor. The next part is informing the owner. The next part is informing the owner if the pet has visible sutures that need to be removed, then to come back, and you write the date when to come back, normally 10 to 14 days after the procedure. And then the next thing is medication or special care notes. Okay, and then it would be a good time to go over the medications that the pet is going home with. Go over the directions slowly, repeat them. You know, do they start it tonight? Do they start it tomorrow morning? How often do they give it? Do they need to give it with a meal? What are the side effects of this medicine? What to look for if they're having a reaction to it? All important things to go over with the owner prior to them leaving the hospital with their patient. Okay, I'm going to demonstrate how to restrain for different blood draws. The first restraint is for a jugular blood draw. So have the dog sit down and then restrain their head like this. And this way the technician can come and draw blood from the jugular vein right here. The next restraint is for a cephalic vein blood draw. You can have the dog sitting or standing. It's better if they're sitting. And then you just hold their forelimb out like this. Roll it off with your thumb. And then restrain their head with your other arm. And then the last one is for a saphenous vein blood draw. So you're going to have the dog laying on their side. Holding their bottom legs. And also restraining their neck and head with one arm, and then the bottom half of their body with the other arm. And then for a dog, it'll be a lateral saphenous, and they'll draw from this vein right here. For a cat, it'll be a medial saphenous, and you'll hold off by pushing right here, and they'll draw from the medial side of the other leg. Okay, so I'm going to demonstrate how to remove a dog from a kennel. The first thing I'm going to do is make sure I'm approaching at an angle and not standing directly in front so the dog doesn't feel cornered or nervous that I'm coming at her. And then I'm going to talk to her to make sure she's comfortable. Hi. Put the leash on before she steps out. There you go. Now I'm going to demonstrate how to put a dog back into a kennel properly. It's probably going to vary depending on how nervous the dog is. Eleanor's not very nervous, so I'm just going to see if she'll... Come on, Eleanor! I'm going to lead her in. And then before removing the leash, I'm going to close the door so she can't escape, but leave it open enough so I can pull out my arm with the leash. And then close it like that. So now I'm going to demonstrate how to appropriately put on a muzzle. The best way to do it is to go from behind and underneath the dog's face. So because I'm short, I'm going to stand on a step stool. I'm just going to reach around and then slip it on her nose like that. And then clip it. Oh. And then make sure that it's not too tight. Looks good. I'm going to demonstrate how to put an Elizabethan collar onto a dog. First thing I'm going to do is slip it over her head, and I'm going to tie it around her neck. I'm going to tie it just tight enough so that I can fit 2 fingers underneath, but that she also can't pull her head out. I don't want to tie it too tight. So I've got it on there. I'm just going to tug on it to make sure it doesn't go over her head. And make sure it's long enough so that her nose doesn't go around it. We're going to do a quick physical exam on Dolly here before her surgical procedure. First we need to get a weight on her, so if you can get her up on the scale here. And that's 48 pounds. That's good, that was less than 2 seconds. Check the dehydration. She's very well hydrated. Alright, now I'm going to just listen to her heart. Check her heart rate. Listen for any abnormalities like a murmur or an arrhythmia. There's a clock right behind the camera. Listening for any crackles, striders. Sounds good. She's panting right now, so the respiration rate is pretty high. I'm also going to check her pulse strength. Good. Okay. The last thing I'm going to check today is the temperature. Do this last because they normally need it the most. Okay, 102.8. So her temp is pretty normal for being a little bit worked up right now. Everything looks good on her. I would set her, she's having an elective procedure done today to get a mast cell tumor removed. So I would put her ASA rating at a P1. Okay, I'm going to do a quick physical exam on Carol before we prep her for surgery. First I'm going to check her CRT, and I'm also gonna check her gums to see if she's dehydrated at all. That's good. It's less than 2 seconds. Next thing I'm gonna do is listen to her heart and lungs. That's very fast. So her heart rate is about 160. That's pretty normal for a cat that's at the vet. Now I'm gonna listen to her lungs. Sound very clear. There's no crackles or anything. Now I'm just gonna check her pulse strength. Alright, that's good. And then the very last thing I'm gonna do is take a temp. And her temp is at 100.8, which is pretty good. So I'm gonna set her ASA rating at a P1. Alright, I'm gonna demonstrate how to do a blood draw on Dolly. I'm gonna use her cephalic vein. So first I'm gonna have Kurt hold off her arm so he's occluding the vein so I can locate it. I'm gonna put some alcohol on there to sterilize it. And I'm going to insert the needle with the bevel facing upwards. Okay, and if you could just hold off right there. Alright, and then I'm going to insert it into my...
Tell your supplies. You're okay.
Alright, I'm going to demonstrate drawing blood from a lateral saphenous vein. It's right here. Kurt is just holding off the vein for me and holding the leg simultaneously. Sure, Mike. This is a cephalic vein on a cat that is anesthetized.
I got 0.8. Yeah.
So this is a jugular blood draw on a cat.
There you go. Well done. Very nice. all done. Okay, that's all you need. Perfect.
Annie, you okay back here?
Okay, I'm going to demonstrate a medial saphenous blood draw on a cat. This is Carol. Kurt is going to restrain her for me. And I'm going to use this butterfly blood collection set. And then I've got my tubes here and a 3 ml syringe. For my personal use. So I have to wash every single one of them. But like, do you think it's about to clot?
Go ahead and do it.
Thank you. Thank you very much.
Okay. It's okay.
Okay, now I'm going to go over pre-anesthetic blood work and tests that we do prior to putting a patient under anesthesia. So the minimum database for most surgery patients is going to be a PCV, a total solids, BG, a BUN, and an ALT. In addition to that, what we run here is a little bit of a larger profile. We include a ALB, alkaline phosphate, creatinine, BUN creatinine ratio, globulins. We also run an electrolytes panel, testing for sodium, potassium, and chloride. And we also include a CBC and a urinalysis. This is what we ran on Dolly. I've got her blood work right here. Basically, the doctor looked at it prior to. So Dolly is 11 years old, so she is a little bit older, but despite that, everything looks great. Her blood work looks great. Her urinalysis was good. For older patients, we add more tests, like we add a thyroid panel. Hers came back normal. And any other additional tests, if it was like a sick patient or something, maybe with like cardiac disease, we might do x-rays of the heart and ultrasound, ECG, or we might even just send them for like a full cardiac workup at the cardiologist to get their opinion on whether or not they are good to proceed with the anesthesia. So now I'm going to go over sort of the standard anesthetic protocol that we use. I'm going to use Dolly's as an example, but because she is a healthy patient undergoing an elective procedure, that's what we do most here. They're the most common. So her protocol is very similar, if not the same, to most of our patients that undergo surgery here. So first things first is her pre-med. So we did buprenorphine and midazolam. Buprenorphine is a very common pre-med. It's an opioid. It's going to help with the pain management, so it's going to prevent the wind-up. Basically, during surgery, she's not going to wake up in severe pain. It's also buprenorphine can also be a sedative as well, but it does also have the tendency to buprenorphine is used kind of to sedate them as well. It can kind of help if they have any anxiety. In addition to that, so it's a buprenorphine. In addition to that, I've got midazolam for her. That's going to go into her pre-med cocktail. Midazolam is Midazolam is a benzodiazepine, so it's also known as like a minor tranquilizer. Because Dolly is old, she's 11 years old, this is going to be really good to sort of calm any sort of anxiety she has, make her nice and easygoing, easy to work with, easy to put the catheter in. She's not stressed out prior to surgery. It makes for a smoother surgery. It's also a good skeletal muscle relaxant, which is helpful during surgery. So midazolam is only really a good sedative if it's mixed with an opioid, which is why we are combining it with buprenorphine today. So those together are going to be her pre-med. In addition to that, what we normally do for pre-med here is a Cerenia injection, just because they come in on an empty stomach, they don't eat all day, they get all these medications that make them nauseous. We find that our patients tend to eat, have less of an upset stomach that evening when they go home if we include Cerenia in the pre-med for the day. Because Cerenia is a drug that lasts for 24 hours, we actually had the owner this time give it at home the night before. She gave it orally. So for an induction agent, we use propofol. That's kind of the most common. I think it may be the only one that we use here, or that we keep here. So for an induction agent, we use propofol. It's the most common. So it's an ultra short acting non-barbiturate. So it's you give it to effect, like all induction agents in small animals. The side effects of propofol is that it's a cardiac and a respiratory depressant. Another benefit to giving it to effect is the rate at which you give propofol is directly related to the amount of dyspnea or apnea that they may undergo. So if you give it very fast, they're more likely to stop breathing or stop breathing for a very long amount of time. If you give it nice and slow, then breath might slow down, but they may not completely stop breathing, or they might stop breathing, but it'll be for a very short amount of time. For our anesthesia, we use isoflurane. That's a common one. We also use sevoflurane, but for most of our patients we use isoflurane, which is what we used for Dolly today. It's good. It's basically good at getting them at a good anesthetic depth without much risk at any sort of cardiac depression or respiratory depression. It gets them at a good anesthetic depth while maintaining their heart rate and respiratory rate pretty well. And also, one of the major benefits of isoflurane is the very quick recovery. So we don't really tend to need to sort of wean them off of the anesthesia towards the end of the procedure. Sometimes once we turn it off, the animal sort of wakes up very quickly afterwards, which is good because that is an indication for a good fast recovery for anesthesia. For our peri-anesthetic meds, we did give Dolly a Rimadyl injection, so that is a non-steroidal anti-inflammatory drug. She did go home on Rimadyl, but we did give the injectable so it could, start kicking in, start working for her. So we gave her a Rimadyl injection while she was here, and we also sent the owner home with Rimadyl, as well as another opioid for pain management and control at home. Also beneficial to help sedate the patient while they're resting for 2 weeks. So because a lot of our pre-anesthetic and anesthetic agents are controlled drugs, we do have to log all of the drugs as we use them. So I'm going to go ahead and demonstrate that. I'm going to demonstrate with the buprenorphine. We get it in this box that has a bunch of miniature vials on the inside. So we give every box a number and then each vial a letter. So I'm going to write the date, which was 7/11/19. Box number 94, and we used vial C. So I'm going to put a C. The animal is Dolly. The owner's last name is Sloss. How much I took, 1.46 mils. My initials. There's a box if we've wasted any, say I dropped some or I missed giving the injection and I have to give it to her again. Wasted, I'm going to put 0. And then an initial for a witness, that would be my preceptor Kurt's initials. So, and then the balance of what's left, so say it's a 2 ml vial, I did 1.46, so there's going to be 0.54 mils left in this vial. And then I'm going to put it back in, and then I'm going to lock it up in the drug cabinet. So there is an example of a drug log. Okay, so this is the anesthesia machine that we use in my practice, and I'm going to go over the parts of it. So starting at the bottom here, we have our oxygen tanks. They're going to supply the oxygen to the machine. We have a sevoflurane and an isoflurane vaporizer. Right now it's hooked up to the isoflurane, and that's what we use most, so I'm going to go through that side of it. Basically the oxygen is going to come out, and then you've got your flow meter. This is going to basically show you, and you can set how much oxygen you want to be flowing into the machine. From there, the oxygen goes into the vaporizer that has the anesthetic gas in it, in this case isoflurane. So this is where the oxygen mixes with the liquid anesthesia, and then it becomes a gas. It vaporizes it. And from there, it goes out to here. So it goes out the inhalation valve, which is this one right here. These tubes connect to the patient, the E-tube. So it goes out the inhalation valve to the patient, and then from the patient, the waste gas and CO2 come into the exhalation valve. At this point, some of it exits through the pop-off valve. Also, it goes into, the rest of it goes into the CO2 absorber canister, where the carbon dioxide gets absorbed. And then once it goes through there, so when we're using a reservoir bag or a rebreathing bag, it exits from the carbon dioxide and the CO2 absorber and into the bag right here. So this inflates. This is full of anesthetic gas, waste anesthetic gas, and also oxygen. So this is a rebreather, so it's more efficient for larger patients to reuse the waste anesthetic gas, so it kind of gets recycled into the system and gets fed back to the patient. This is the manometer, so this is going to determine the pressure of gas and oxygen that is being oxygen flush valve. When you push the flush valve, it flushes oxygen and it bypasses the vaporizer, so you're sending oxygen, just plain oxygen, directly to the patient. This is the non-rebreather. So one end hooks up into the export side of the vaporizer, so the vaporizer comes in and then it goes through these tubes. This part goes to the patient, and then when they exhale, it goes straight into the scavenging system. So for smaller patients, use the non-rebreather because it's actually not as efficient for them to be rebreathing the waste anesthetic gas. I'm going to demonstrate a leak test on the anesthesia machine. First thing I'm going to do is close the pop-off valve. I don't want any place for air to be able to exit, so if there is a leak, I'll be able to notice it. I don't want any place for oxygen to exit, so if there is a leak, I'll notice it. Then what I'm going to do is turn the oxygen on. I'm going to put the palm of my hand over this so that no oxygen can leak out over here. Then I'm going to watch the manometer till it reaches 20 and watch the bag fill up. So make sure the bag is filling up, and it is. And the gauge is starting to reach 20. And then once it does, I'm going to open the pop-off valve. And didn't hear any leaks or didn't see any issues with that, so that went perfectly. So this is the pulse ox. It's measuring her SpO2 and also her heart rate. And then that is just connected to her tongue right here. The next thing is the esophageal stethoscope. So this is inserted into about her 5th rib. And this is what I'm using to listen to her heart. I can also get a heart rate with this. Okay, another thing that we're not using today is a gastric tube. That goes in all the way down to her last rib. So it goes in further than the esophageal stethoscope. Also, when you're removing the gastric tube, you need to make sure to pinch it off before you pull it through. Her blood pressure is being monitored through this machine right here. This is hooked up to a cuff on her front limb right there. Okay, so also her temperature is being monitored through this probe. This probe is monitoring the ECG, and it's also monitoring her temperature on this machine right here. So this is her temp right here. Here's her ECG, heart rate as well. Okay, I'm going to demonstrate how to use an ECG and get a reading on this dolly here. She's positioned in right lateral recumbency. So the white lead goes on her right front limb, black on the front left, and red on the rear left. And I'm going to wet the leads with alcohol to make it read. So now it's reading. So you can see at first there are a lot of artifacts. That's because it was still getting started and there may have been some motion. So a way to prevent artifacts is make sure all of your leads are wet and just reduce any type of motion because it will pick up motion. So her ECG is good. You can see each of these is called, so it's a P, Q, R, and an S wave, and a T wave. So this little first one is the P, and then this is a Q, R, S, and then the T is the wave right at the end. Those are all a good distance from each other, and between each QRS is a good distance, so her ECG looks good. monitoring her respiration rate through the bag directly, so I can see her breaths from the bag. I'm going to demonstrate the function of an E-tube. Later in the video, you're going to watch me intubate a patient with one. But prior to doing that, I need to select my size. I select it by measuring it on the nostrils of the patient, right in the middle of their nose. Once I pick up my sizes, I'm going to check them for leaks. So basically what I'm going to do is take an empty syringe, got a 10 ml syringe here. I'm going to push down and plunge it with air. Make sure that both ends fill up. So I need to make sure this is being filled with air, and so is this, because this is how I'm going to monitor it once it's inside the patient. So I'm just checking to see if it's holding the air, if it's got any leaks. Most of the time I'll kind of let it sit there for a little bit because sometimes there'll be a slow leak. Once I determine that it's okay for use, I'm going to deflate it. And then I'm going to lubricate the end with some sterile lube prior to inserting it into the patient. The purpose of the E-tube, basically this is where the anesthetic gas and the oxygen is going to be getting to the patient. It's also ensuring that if they were to regurgitate any fluid, it would not aspirate into their lungs. This is Maggie. She's been pre-medded for surgery, and I'm going to demonstrate how to put a cephalic catheter in. I'm wearing a lab coat over my scrubs to protect my surgery scrubs from any hair or dander, anything that may contaminate them while I put in the catheter. So, oh, and this is my preceptor, Kurt, and he's gonna assist me today. If you could position her for me, please. And I'm gonna begin by trimming the hair around her arm with a 40 blade. I'm completely blocking that.
Good girl, Maggie. She's a good girl.
And because she's got very long hair, I'm gonna go all the way around her arm. Alright, now I'm going to scrub the area 3 times. I have some gauze with some Chlorhex scrub and some alcohol gauze to wipe it with. So I do the Chlorhex first. Okay. Alright, now I'm going to put in the catheter. I have a 22 gauge catheter. I need to flush that first. I've got a T-port that has been flushed, and then I've got my syringe full of flush here. Okay, and I've already pre-cut my tape here. So we're are ready to go. Alright, Kurt is rolling off the arm for me. And I'm just going to go in until I get a flash of blood, and then once I do, I'm just going to continue to push the catheter forward without pushing the needle in. So there's my flash. Okay, and Kurt, if you could hold off right there for me, please. Now I'm going to put the T-port on.
I've got it on.
Okay. All right, now I'm just gonna put the first piece of tape on just to secure it into place. Guess I thought she was a lab. And then I'm gonna flush and make sure that it is in. And Kurt is gonna feel for me. She's trying to pull her arm back.
Yep.
Alright, so we're good. So I'm going to continue taping. My next piece of tape is gonna go underneath to help support the underside. And then my next piece of tape is to support this port right here. It's gonna go on. And then the final piece of tape I have is to tape this part of the T-port down to the arm like this, so that it's not flopping around. Good girl.
Good girl.
You are. Okay, now I'm just gonna give it another flush to make sure we're still in. Okay. Okay. Now I'm going to secure this with a bandage. Okay, I'm going to demonstrate how to place a lateral saphenous catheter. First, I'm going to shave an area on the leg. Then I'm going to scrub the area 3 times, rinsing with alcohol wipe in between each scrub.
You too, Billy. How's it going, lady?
Okay, now I'm gonna place the catheter. I've already flushed it. I have a syringe of flush pulled up, and I've flushed my T-port as well that I'm going to use. Alright, so I'm gonna put my first piece of tape on, just so it doesn't move around, and then I'm gonna flush it and make sure that it's in. Okay, so that's in, and the way I can tell is because when I flush it, I can feel it going through the vein up here. Also, if it was not in, then the fluid would build up in the sub-Q space from the flush. So I'm going to continue taping. Come on, darling. Good girl.
Hey, darling, you stay. You stay. Okay, you stay.
Make sure this is closed off. Flush one more time. Okay, throw a piece of vet wrap on here just to protect it. This is Sergeant Pepper. He is a male Havanese. He's 7 months old. We are going to be neutering him today, so I'm going to pre-med him IM. I have his pre-med pulled up right here. It's 0.19 mils of buprenorphine and 0.05 mils of midazolam. So, to give it IM, I'm going to find the last rib and his hips, and go right in between the middle there, and then 2 fingers away from the spine. And go straight in. Yeah, buddy. Good boy. Okay, this is Rose. She's a 13-month-old pit bull. We're gonna spay her today. She's a female. This is her pre-med for her surgery. It's 1 mil of buprenorphine with 0.3 mils of midazolam, and I'm going to give it to her IV. So if you could just roll off for me, please. Prep the site with some alcohol. Okay, pick up. our Havanese that we're neutering today. We already have him intubated, ready to prep for his surgery. But first what I'm going to do is give his Medicam sub-Q so we can have that on board for the surgery. And what I'm going to do is I'm just going to pinch up his skin and make a little tent and inject it right underneath his skin. Okay, so Dolly's got her catheter and she's been pre-medded for surgery, so we're going to go ahead and intubate her so we can then prep her. I'm going to start by flushing her catheter. Still good. Alright, and then I'm going to intubate IV with propofol. And I'm going to give it to effect. So I'm watching for her. She might go through an excitement phase first. Hopefully she'll stop panting. Slowly start to lose her palpable reflex, but I think I need to do more of this first. Checking the jaw tone. Still pressing. Okay, that's a good sign. Alright, so I'm going to flush your catheter first. And then I'm going to use the laryngoscope and some gauze to visualize the opening of your trachea so I can insert the V2. Okay, you're panting again. Okay. And a little bit more. Just a nice long sock belt. Yeah. No, I can see. Alright, so I'm just going to insert this. I've pre-measured how deep it needs to go up to so I can tie it around her head. Make sure it fits in. Okay, so I can mostly tell it's in now because I can see her breath through the tube. Alright, we'll lay her down for a minute. I'm going to inflate the cuff. Here. Okay, and if you'll do a positive pressure check so I can listen. So Christy's doing a positive pressure check and I'm listening for any leaks or hissing around the cuff or the tube. so I can tell that it's inflated. I think I need to inflate it a little bit more. But I want to be careful not to overinflate it because that can do damage. So she has got her E-tube in, it's inflated. I'm going to hook her up to some monitoring equipment, and I'm also going to lubricate her eyes so they don't dry out because she won't produce tears while she is under anesthesia. So as part of the patient preparation, I'm going to palpate her bladder and make sure she doesn't have any urine. If her bladder is very small, so I don't need to express it. There's nothing to express in there. So now I'm going to prep Dolly for surgery by shaving and cleaning. Basically, we're taking these two masses off today. I've already asked the doctor how wide she wants her margins to be, so that's how far I'm going to shave. I'm going to do that first with a 40 blade on my clippers. And it's really important during this part to try to keep your lines as straight as possible. For a clean shave, you want to be very symmetrical because this is, other than the incision with the sutures, it's the only part really that the client is going to see. So if they see a symmetrical straight shave job, then they're going to have confidence that also the surgery was clean and that they did a good job. Another thing to note is that I am wearing a lab coat, and this is to protect my surgical scrubs from getting any excess hair on them because I want my surgery scrubs to be clean. How's she doing?
Good.
Also trying to get as close and be careful not to give her any razor burn. Kind of pulling her skin around her shoulders there. Okay, now I'm gonna vacuum up all the hair. Okay, now that she has been clipped and I vacuumed up all the hair, I'm going to start the surgical scrub. The minimum I want to do it is 3 times, but obviously if she's still dirty after that, I will keep going. Basically, this is some Chlorhex scrub, and I have some alcohol gauze to rinse with afterwards, in between each scrub. What I'm going to do is called the target pattern, so I'm going to start in the middle of the site and then move outwards, so I'm not moving the gauze over the same place that it was in before. And then I'm going to do alcohol in between each one. In the same target pattern. Also, I removed the lab coat at this point because I was wearing it to protect my scrubs from hair. There was a lot of hair while I was shaving, so I don't want to be dropping little hairs onto her. And this one. That was one, right? Okay, so now she's ready to move into the surgery suite. As soon as we get her in there in position, I'm going to do one final scrub on each of these sites. We're going to transport her onto the surgery table now, so I'm turning her off of the gas, disconnecting her from her E-tube. This part. never sweated so much in my life.
Are you gonna mute this part?
Yeah.
So, do you want your pulse ox back on?
Please. Okay, so while my preceptor Kurt helps me get her hooked up to all the monitoring equipment, I'm gonna do the final scrub.
Ready? You're filming.
Okay, so while she is undergoing surgery, I'm monitoring all of her vitals. About every 5 minutes, I'm monitoring her heart rate, respiratory rate, CRT, making sure she still doesn't have any reflexes going on right here. Every 15 minutes I'll measure her temperature, measure the oxygen flow, gas rate, all of that. So I'm keeping a log of all of those readings so I can look for any trends or major differences throughout her anesthesia.
Yes.
So I'm going to write down the gas rate that she's on right now. Temperature, 98.7. Another way to make sure that all of these things are reading is to get a rectal temperature occasionally. Where's the clock? Okay, so she's 20 breaths per minute, which is good. SpO2 is 100. Heart rate is 89, and I can use the esophageal stethoscope to also double check that reading. Then her blood pressure, the map right now is 70.
Good.
Okay, so we're going to demonstrate CPR on a patient. Say they're undergoing surgery and they begin to crash. So the first thing I'm going to do is listen and make sure that regardless of what my monitoring equipment is telling me, I want to make sure there actually isn't a heartbeat. Okay, so there's no heartbeat. So immediately I'm going to start chest compressions. For a small animal, I'm going to support the underside with my 4 fingers and then use my thumb. And I want to do about 120 compressions a minute. Carl's going to attach an ambu bag to the E-tube. And while I'm doing compressions, I'll take a break and then let him give some breaths. And he's going to give about 8 to 12 breaths per minute. If this was a larger patient, I would do the compressions like this. Of course, I would move the arm out of the way. Use both of my hands. They would only need about 100 compressions per minute. Still 8 to 12 breaths per minute with the ambu bag. Is there anything else? Okay, I'm going to demonstrate how to scrub in for surgery. First, I would remove any jewelry if I was wearing any, and I'm not. Now I'm gonna put my cap and mask on. So I'm going to use a sterilized scrub brush with some Chlorhex scrub. So I'll get my water on. And then the first thing I'm going to do is just wash my hands regularly. Then I'm going to open my brush. Put the scrub on. And there are 4 sides to my hand. So I'm going to scrub each of the 4 sides of my hand and all of my fingers, and then down my arm to my elbows for 10 seconds on each side for a minimum of 10 seconds. Notice that I'm keeping my hands straight up. So that if any of the scrub runs, it goes from clean to dirty, not dirty to clean. Now to rinse my hands, I'm going to keep them upright so that the water runs down. And I don't have any water running from the unscrubbed part of my arm down to the scrubbed part. Now I'm going to go dry my hands. So the most important part is to be careful not to let the towel touch my scrubs. This is a sterilized towel. My scrubs are not sterile. Also, Not to let any part of the towel that I've already used touch a part that I haven't scrubbed. Okay. Now I'm gonna get my gown on. Well, not to touch anything. And I'm gonna have Kurt set down the camera for a second and tie me in. I don't want my fingers, I'm gonna do a close gloving, so I don't want my fingers to go beyond the sleeve, the cut of the gown.
Yeah.
Okay. So grabbing the glove through the cuff of the gown. Just want to grab the outside. And then stop recording.
Mm-hmm. Still. You've got a lot of editing to do.
Okay, that's fine. So this is Tucker. We're going to neuter him today. He's a 7-month-old golden doodle. I've scrubbed in and I did a closed gloving. And now I'm going to set up the instruments for Dr. James and also drape him. He's already been shaved and scrubbed. So So now I'm going to go ahead and drape. And I'm going to do a fenestrated drape. First. Alright, so I'm going to do a fenestrated drape. So I'm going to cut the hole first. And I'm going to drape it over, being sure not to break my own sterility and also not to get the bottom side of the drape anywhere else but on the patient. And I've got clamps. The scalpel blade onto the handle.
I would like you to hand me the scalpel, please.
Okay. Cool.
Thank
There
you.
you are.
Alright.
So this is more likely to be used in like an abdominal surgery, but just to demonstrate, in order to keep all of the internal organs moist, we have some gauze soaked with saline that Dr. James is going to put around the area.
Hmm.
Well, you put it there so that it's not in your way.
Pretty
Perfect.
much it. Mhm. Okay. Alright. May I have the brown Addison forceps? You are correct. Well done. There's also a third option. It's not.
Okay. There you go.
Thank you.
So when there's bleeding, it is important to blot instead of wipe, just in case if there's any clots forming, you don't want to wipe any of the clots away. So I'm just gonna blot for you right there. Is that what you wanted?
Yeah. A little bit more. Perfect.
So I just demonstrated sort of the duties of a surgical assistant. One important thing to note is maintaining the hemostasis. So basically being prepared to hand hemostats if the surgeon punctures a vessel or cuts a vessel. Being familiar with the procedure, knowing kind of what they're gonna need next. Another thing is maintaining sterility, you saw I stood there with my hands like this to avoid touching anything that was unsterile. I never turned away from the surgery field, no reaching over the patient or the surgery field for that matter. Another thing to remember is if you do break sterility is to let everyone know so that we can address the situation. So say if you puncture a glove, changing out that glove for a different glove and also replacing the instrument that also punctured through your glove. Things like that, if you drop an instrument, replacing it with another one. Yeah.
Hi, this is Rose. She is a 13-month-old pit bull. She's here for a spay today. She's been positioned, intubated, and has been induced. So Emily here is going to be assisting the doctors, lasering, and just assisting with any of her needs in surgery.
Oh, you put mine back around here. Sorry.
It's okay.
Perfect, thank you. Ideally, we wouldn't.
Go over it.
Yeah, but that was my fault.
It's alright.
Okay, I'm on my last sub Q. Can you grab some 3-aught ethylene for me?
Yes.
Thank you. Wonderful.
Okay.
Hi, I'm Kurt Crocker. I'm Emily's preceptor for this course, and unfortunately we didn't have a feline spay or neuter scheduled during the course of this class, so she has in fact helped me on multiple ones of those surgeries, each one. She's also assisted in less routine surgeries, foreign bodies, cystotomies, anal sacculectomies, as the most recent thing she's assisted with off the top of my head. She is very competent and able and aware of everything she's doing in there as far as the monitoring equipment goes, and I'm very excited to have her as a member of our registered veterinary team.
Okay, so to clean up the surgery suite, I'm gonna start by taking all of the sharps away from the area and dispose them in a sharps container. I'm going to count all the instruments in the gauze and make sure we have the same amount as we did before starting the surgery. And I'm going to wipe down all of the flat surfaces in surgery, including the floor and for the whole suite. Also, any areas that have been like visibly like splashed or anything, like the wall or certain parts of the floor that are kind of far away, I'm gonna clean that up as well. Okay, so using the rescue cleaner disinfectant, I'm going to clean the surgery suite. I'm going to wipe the table, the instrument stand, any machines that we use today, and as the floor as well, and any obvious soiled areas like on the wall or the door or anything. I'm going to clean that as well. Now I'm going to take all the utensils, put them back in this little tray so I can soak them in a disinfectant. This will be helpful to go ahead and start to work off any of the blood that is on there, anything stuck in between, you know, sort of the box locks. Make sure all the box locks are open so we don't miss any spots. Okay, so the instruments have been soaking in a pre-soak, which is just water with disinfectant. Now I'm going to decontaminate them by scrubbing them with a scrub brush, soft bristle brush, and as a detergent. Okay, now I've got some distilled water that I'm going to rinse them off with. This is going to help prevent any sort of like buildup or scale that can happen with just regular tap water. So I put some distilled water right here to rinse them off. Okay, now that my instruments have laid out to dry, I'm going to move them into the ultrasonic. So after the instrument's finished in the ultrasonic cleaner, I rinse them off again with distilled water, and now I've put them into this tub full of instrument lube. Then I'm going to take them all out, spread them on the towel, and then they will be ready to be put into the surgery packs. Okay, so I'm going to demonstrate how to wrap a spay-neuter surgery pack. First thing I'm going to do is put in the gauze squares. So we put 12 squares in every pack in 2 piles of 6. So I'm going to count out my gauze and make sure I do 6. And then 3. Okay, then I have a spay hook, and everything in this pack has a black band around it, so that's how I know that everything goes together with the black band. So there's hemostatic forceps. I'm going to make sure that the box locks are open when I pack them in the pack. I'm going to put the larger size ones in first. Then I'm going to go ahead and put my steam indicator strip in, because that needs to go into the middle of the pack. This is going to indicate that the conditions for sterilization were met. Right now it's white, and then after the pack is autoclaved, there should be a black line. So make sure that is in the middle. And then I have my towel clamps. Okay, now I'm going to demonstrate how to wrap the pack. We use the reusable linen wraps here. I have it laid on the table in sort of a diamond shape, and I've got the pack right in the middle. I'm going to start from the top. I'm going to pull this over the pack and then fold it back and create a tab, so that when it's sterile and we're unwrapping it, it's easy to just grab the very end of the corner there without breaking the sterilization for the rest of the wrap. Then I'm going to do the sides. Fold that tab in. Same thing, make a tab with the corner. Other side. Very last piece, I'm going to fold it over the top, tuck it up under the 2 side pieces that I folded in. I'm going to make sure I leave the very corner out to be a starting tab to open the pack by just grabbing this little corner piece. Then I'm going to put my steam indicator tape on there, so that after it comes out of the autoclave, you know which packs are autoclaved and which have been not. Also make sure that the pack doesn't fall open. So I'm going to wrap it nice and tight all the way around. And then I'm going to label the pack. So this is the black because of the black bands. Spay, neuter pack. I'm going to put my initials and then today's date. And now it is ready to go into the autoclave. Now I'm going to demonstrate how to wrap the gown in a towel. So I have the gown laying open side down with the sleeves on top, and I make sure the sleeves are straightened out. Make sure they're not folded into each other or crumpled up. Then I'm going to fold each side in. And then I'm going to fold them in again. And then fold it in the middle. So now it's accordion folded lengthwise. Now I'm going to do the accordion fold again, long ways. Make sure that the strings are accessible at the top there. Okay. Now I'm going to fold the towel in a similar way, so that it is like an accordion. And that goes on top. Now I'm going to get my steam indicator strip for this, and it needs to go into the middle, so about right there. And then I have my wrap in the same way that we wrapped the spay neuter pack. So I'll have it laid on the table like this, with the gown and the towel in the middle. I'm folding it over and creating a tab. Top, sides, and then the bottom. I want it nice and tight. Leaving that tab out for easy access. Then I've got my steam indicator tape. And I'm going to write gown and towel, my initials, and the date. And now this is ready for the autoclave. Okay, so now that my instruments and my gown are wrapped, I'm gonna put them into the autoclave so they can be sterilized. What the autoclave does is it uses steam under pressure to kill microorganisms. When I'm loading things into the autoclave, I want to make sure not to overload it with too many things, and I want to make sure that what I'm putting in there is in the center and isn't touching any of the sides of the autoclave. The first step is to fill the chamber with distilled water. So I have a switch over here, and there's already distilled water in here, so now it's just filling up in the chamber. I'm just gonna wait until it fills up all the way. Okay, so now that there's enough water in there, I'm gonna shut the door and make sure that it is locked and shut tight, because what's gonna happen is steam is gonna build up pressure in here, so we don't want the door to be able to open, or else we won't be able to build up enough pressure. It needs to reach anywhere between 15 to 27 psi. In order to do that, I have it set to 273 degrees Fahrenheit, and then I'm going to run it for about 20 minutes. So for autoclave maintenance, what we do is we clean it about once a month. We have this special cleaner for it, and what we do is we drain it and run it on a cleaning cycle per the instructions of the cleaner. Yeah. Okay, so the timer for the autoclave just went off, so now I'm going to switch it over from sterilize to drain. So now it's draining all of the steam out, basically, that has built up pressure. And there's a pressure gauge here that I can watch and go down Once it's down to 0, then it is safe to open up the door. If I opened it before then, there would be too much pressure. Okay, now I'm going to open it. There's going to be a little bit more steam that comes out, so I want to be careful. Now I'm just going to open the door a little bit, about an inch, and I have it set to dry, and I'm going to do a timer to dry it for 15 minutes. So the timer for the drying cycle went off. I also waited an extra couple of minutes because it can be very, very hot if you just try to go in there and take the packs out. So I think it's cooled down enough to be able to handle. Just in case I'm not going to touch the metal tray, I have this tool to pull it out. You can see that this pack has been through the autoclave because now the steam indicator tape has these black lines on it. So that's how we can tell just by looking at the outside of the pack that it has been through the autoclave and we can use it in surgery. This gown pack also, my marker leaked a little bit, but you can still see the lines on the tape. So I am about to demonstrate a suture removal. Prior to removing the sutures, I need to inspect the surgery site. What I'm looking for is if the wound is actually, or if the surgery site is completely closed, if there's any redness, swelling, discharge. Those would all be indications that the wound is not healing properly and it needs a doctor's attention. First things first, I'm gonna check the incision, make sure it looks good and that the sutures are okay to be removed. And then I'm gonna use forceps and some suture removing scissors. And basically, I'm gonna use the forceps to pull the sutures away from the skin. I'm sorry, honey. Do the suture with the scissors and cut next to the knot. Oh my goodness. Are you able to? No, you're not. Don't worry about it. Here, let me start up here. All right, that looks great.